Hello guys, we are back with congenital heart defects, chapter 4, part 5, and we get to move into some fun stuff here. And that sounds so not right because we're talking about diseases, but we get to really start applying clinical applications here and get to think in fun ways and look at different ways that we can diagnose and figure out some of these diseases from a pathophysiological presentation. And so we are moving into congenital heart defects, which obviously these will be heart defects that happen at birth. And it's the most common type of birth defect, which is an interesting fact. And there's several examples that I'm going to give you, and then we're going to practice looking at these. So we're going to define them, and then we'll look at pictures of them and try to guess which they are. So, septal defect are holes in the wall in between the two chambers. It can happen between the atria or the ventricle. And the one example we're going to look at is patent foramen ovale. When a child is born, upon their first breath approximately, and if not that soon, very soon thereafter, there is actually a bypass that goes between the right and the left atrium. And we have bypasses in place in the fetal heart because the fetus doesn't have to breathe for itself. So we bypass the lungs and we send blood from the right side of the heart basically straight to the left side of the heart, in order to bypass the lungs and send that fresh oxygenated blood from the mother out to that baby's system. There's two bypasses that we're going to talk about here. The first one is called foramen ovale. It's a little oval hole between the right and the left atrium. And so nice, fresh oxygenated blood from the mother will return to the baby's heart, go into that right atrium, and it can go right into the left atrium and out into the baby's body. It's pretty cool. And I have a picture that'll help to clarify that. When a baby is born, that should close, and it turns into fossa ovalis. You may remember that, may not. That's okay if you don't remember. I want you to remember foramen ovale. Anyway, in a baby, when they are born, that should close, and it closes permanently. Well, in some defects, it stays open partially or quite a bit, and you could get what's called a blue baby. The next defect that we see is patent ductus arteriosus, and this ductus arteriosus is a little blood vessel between the aorta and the pulmonary trunk that, upon birth, this should also close. So patent ductus arteriosus, this is going to be that small blood vessel, sorry to positive for a second there, the small blood vessel between the aorta and the pulmonary trunk. And this, once again, is a bypass because the pulmonary trunk goes to the lungs. So we actually have a little blood vessel that'll circumvent the lungs and send blood into the aorta to be sent out to the body. So if an infant is born and this doesn't close, they actually keep a little opening between the aorta and the pulmonary trunk. And don't forget, the pulmonary trunk comes from the right side of the heart, the aorta from the left. You're intermingling oxygenated and deoxygenated blood. Usually upon birth, when a child is born, with their first breath, it creates enough intrathoracic pressure that it will close off that patent ductus arteriosus, and it turns it into a little ligament. Valve disorders are valve disorders. We've gone over them. This can happen congenitally as well, so I didn't really put much down for that. Tetralogy of Fallot. This is a culmination of issues that happen with a child. For some reason, they like to happen together. And the series of events that cause these defects probably come from the same lineage of cells. So as you start to develop and your cells start to differentiate, the cells that create the heart are going to come from the same line of cells, and some defect happens that causes these multitude of factors to go wrong. So the pulmonary valve is stenosed, which means narrowed. There's a large ventricular septal defect. That means it's basically open, the right and left ventricles. There's misplacement of the aorta. It goes right over that ventricular septal defect, so it comes from both the ventricles. And the right ventricle is hypertrophied, much like the left ventricle. So all of those things obviously are going to be a huge issue for an infant. It'll have to require tons of surgery for that child to survive. Now, I did a whole bunch of let's practices here, and I thought this would be a lot of fun, especially with heart. So congenital defects, let's piece these together. You could probably figure out this one because I had to cover so many things. But let's look at the heart itself. So if we look at the heart, I'm going to help you just a little bit with this one. One of the first things that is marked off, try to look at this and think about what valve this is. Okay, and does it look like the normal width or does it look narrowed? Here's the right ventricle. Here's the left ventricle. Here's the wall between them. I'm going to erase this. Does that look normal? You're like, yes, I already know what this is, Dr. D. Right? Look at the right ventricle compared to the left. The thickness of the walls, is that normal? Absolutely not. So this will be tetralogy of Fallot. Okay, and I have that covered up for you. Here we have pulmonary stenosis, the septal defect between the ventricles, because don't forget there can be atrial ones, hypertrophy of the right ventricle, and then increased outflow of blood in the aorta. Okay, and then, did I just move this aside? Yeah, I just moved this aside. Okay, so tetralogy of Fallot. So if we take a minute and look at this, let me explain once again where we are. Obviously, we're in the heart, okay? And we're obviously at the circle, because why else would I have that highlighted? So if we're at the circle, we're looking at what vessel is this? It's coming off the right ventricle, pulmonary trunk. And what vessel is this? Aorta, specifically the arch of the aorta. And the connection between them, that is going to be the ductus arteriosus. Okay, so this is called patent ductus arteriosus. In an adult, that should close. And if I were to pull out a dissected adult heart, we could actually see the little ligament that it turns into. It connects the aorta to that pulmonary trunk. Last but not least, I'm going to let you take a peek at this on your own. And you're probably all guessing it. You can see where we get blood flow coming in. It should be going through that tricuspid valve. And it should not be doing this unless it's an infant heart. This is one of those bypasses I told you about, where we're going to have direct connection from right to left side of the heart. This one will be patent foramen ovale. Is this one here. And upon the first breath, after a child is born, that closes in a normal presentation and it becomes just a little indentation. And once again, if I were to dissect the heart out and show you, you would see a little round circle between the right atrium and the left atrium. It's kind of cool. Cardiac conditions leading to altered tissue perfusion. So we need more power. We've got to get the blood out to those tissues. We're not getting it out for some reason. So let's look at the possible causes. It obviously would be something to do with the blood vessels not being able to get the blood out to those tissues, and an aneurysm is a great example of this. So an aneurysm is a weakening of an arterial wall. Common areas. This should be bread and butter stuff for you. AAA, abdominal aortic aneurysm, and that'll be below the diaphragm. You can get one in the thoracic, which will be above the diaphragm. It's not going to be as common. I want to explain to you why. Aneurysms can form anywhere. But more often, and this is in the notes somewhere, I know it is, but I'm going to draw it out here. They like to happen where a blood vessel bifurcates. The abdominal region of the aorta comes down and it bifurcates, which means splits, into the common iliacs. If you don't remember that, you better go review it. Okay. All right. So this is going to be the aorta bifurcating into the common iliacs. So blood is coming at a high pressure. It hits that bifurcation. There's a little backflow, just a slight amount. So this backflow can form clots, but it can also create an increased pressure in the abdominal aorta because you have a little bit of backflow in that region. Okay, and that's true of clots as well. I think that's actually where I put it. So aneurysms can also happen in the cerebral, femoral, and popliteal arteries. So cerebral obviously is brain, and that's a bad thing because if that aneurysm or distension of that artery goes too far, it can break open and we can bleed out. That would be very bad, okay, which is when it ruptures there. Popliteal arteries can go behind the knee, and that's a bad thing because it can look like that Baker's cyst. I don't know if you've ever heard of that. Baker's cyst is a cyst behind the knee. Well, that's where the popliteal artery is, as you know. So people think it's a Baker's cyst. It's really an artery. So you always palpate it gently and see if it is doing what? You know what? Pulsating, right? Okay. So femoral artery as well would be a bad area to get a clot. Now, true aneurysms affect all three vessel layers. You can get a saccular one, which is a bulge to the side, or a fusiform, which it affects the entire circumference, so it looks like it bulges out on both sides. I once again have a picture I'm going to ask you some questions on, and we'll review it on there. Now, a false aneurysm doesn't affect all three layers of those blood vessels, and what I mean by the three layers is what we went over in the anatomy of blood vessels. Those three layers include the tunica intima, the tunica media, and the tunica adventitia or externa. Okay, so those three are the ones that we're talking about. The true aneurysm, it will distend all three of those layers out. With a false aneurysm, it doesn't affect all three layers. Our example for this is a dissecting aneurysm. So what this does, and this happens in the aorta, is you'll get a little bit of a rip in one of those layers and blood will get between them. So that is called a false aneurysm. I think you've probably heard it as a dissecting aneurysm, where it doesn't distend all three layers, it gets in between the layers. Dyslipidemia means high levels of lipids in the blood. This will cause an increase for risk for many chronic conditions. Atherosclerosis, heart disease, difficulty in getting blood out to the tissues would be examples of what can go wrong. So we know lipids come from our diet. Primarily cholesterol will come from animal products and triglycerides will come from saturated fats in our diets. That's why we need to watch our diets a little bit if we have dyslipidemia. So when we eat food and we get lipids or fats into our body, we have to link the lipids, or I should say combine them with a protein. Otherwise, the lipids will separate out. It's just like oil and water. If I were to put just lipids into your bloodstream, it would separate out. If we link it with protein, we get a molecule which can actually spread throughout the bloodstream and distribute fats out into the tissues. Fats are a necessary part of our diet. We do need them to a certain degree. It's a matter of keeping the proper amounts of fats. So we combine these fats with proteins to get a unit called a lipoprotein, and that's where we get the names for those fats that we test, or the cholesterols that we test in our diets. Now, there's different types of lipoproteins. There's very low density lipoproteins, and the majority of the fats that carries is triglycerides. Low density lipoproteins carries cholesterol. Both very low density and low density lipoproteins will take fats and put them into the tissues of our bodies. And very low density lipoproteins, we actually, when they're created by the liver and they're put into our bloodstream, they'll dissociate into triglycerides. They'll get rid of the triglycerides and actually turn into low density lipoproteins. It's kind of confusing. Don't let that blow your mind. Remember that very low density lipoproteins carries the most triglycerides. Low density lipoproteins carries the most cholesterol. Very low density and low density are carrying those fats to go out into the tissues for the fats that we need for the cells of our bodies and hormones and etc. High density lipoproteins. This is a lipoprotein that's mostly protein. And this is what gathers excess cholesterol from our tissues and our bloodstream, brings it back to the liver to be gotten rid of. And when we're talking about low density and high density, it's whether it's more lipid, which is a low density, which would be your VLDLs and your LDLs. So much easier to say it that way. Or a higher density lipoprotein, which is your HDL, which is going to be more protein, and that's your good cholesterol, which will sop up that extra fat from the body. So VLDL, it begins as VLDL in the liver, loses some triglycerides, and is turned into LDL in the blood. This is going to be the major carrier out of the liver of triglycerides into the body. LDL, most serum cholesterol is in LDL. This distributes cholesterol out to the tissues. So in order to decrease this, we have to decrease our intake of cholesterol. Here's a bad thing, is the liver will still make some triglycerides and cholesterol anyway. But anyway, if you decrease your intake, it will help lower your LDL levels. HDL helps to remove cholesterol from the bloodstream in the tissues, to increase LDL, HDL levels, lifestyle modification. So the more foods you eat that have bright colors, your spinaches, your fresh fruits and vegetables, wine, or even grape juice, helps that HDL to increase. Nuts also help HDL to increase. So those help to raise that HDL level. And as you know from blood tests, it's all about the breakdown and the percentages and the ratios as well. So dyslipidemia has a multitude of factors. So here is the primary target. Here are your numbers. I'm sure these look familiar. I'm not going to rattle them off. You know, total cholesterol is hopefully less than 200. LDL less than 100. I think the big numbers I think would be a good thing to remember. So LDL less than 100, total less than 200, triglycerides less than 150. HDL, you want it to be higher, don't forget. So less than 40 is low. You want it to be higher than that, you know, hopefully about 60. Atherosclerosis. When we're looking at a blood vessel, and I've mentioned this a couple of times, and if we look inside it like the end of a hose, chronic inflammation can damage the inside or the tunica media or interna of blood vessels, and that inflammation can lead to hardening of arterial walls. So inflammation draws fat to it. You get what's called a fatty streak. That fatty streak can continue to grow, and we can actually adhere clots to it with atherosclerosis. So it's usually triggered by some sort of vessel wall injury. We actually get mast cells. I don't have this in the notes, so you don't need to. Mast cells there which start to then draw fats, and it develops these plaque-like depositions in there that can eventually harden and calcify. This can obviously lead to vessel obstruction. Like I said, you can have platelet aggregation leading to a clot and vasoconstriction as well. I think that's a little misleading, the vasoconstriction. It's not that it's constricting the blood vessel. There's some things, of course, I disagree with the book. It decreases the diameter of the blood vessel. So just as a little, my usual type A thing. I wouldn't say vasoconstriction. I'd say decreased diameter. I'm not going to write out diameter. Okay, so decreased diameter simply because you're depositing cholesterol, fat, calcium, possibly blood vessels into that opening of the blood vessel, which makes it narrower. So complications: peripheral vascular disease, MI, coronary artery disease, thrombi, hypertension, and stroke. And it would be hypertension because your blood vessels are hardened and they're not as resilient as they are with somebody without atherosclerosis. Stroke because you could throw a blood clot. I put in your supplemental media a cool little video on angioplasty, and I'm sure it's old hat for you guys, but if you haven't reviewed it for a while, this is a nice picture, but the video actually goes step by step on those steps of angioplasty, so make sure you review that. Peripheral vascular disease, narrowing of the peripheral vessels. This can be due to atherosclerosis, a clot, inflammation, vasospasms. Two examples that we're going to give you here is thromboangiitis obliterans. This is an inflammatory condition of the arteries which can lead to damaged and necrotic tissue. Eek. Probably one you've heard of more recently is Raynaud's disease. This is vasospasms of the arteries, usually in the hands. It can be due to sympathetic stimulation because don't forget, the sympathetic nervous system causes vasoconstriction in blood vessels. I know patients, and I know your book says this is usually an autoimmune condition, but I know patients who this has begun as repetitive exposure to cold conditions. Maybe that leads to an autoimmune condition, but I've known of 3 or 4 people who have had this. It always started with their farmers. I think most of them were farmers actually, and they would work outside without their gloves. Cold hands, cold hands, cold hands, and eventually their body started to have a very overreactive response to it, where they have this initial opening of the blood vessels, which turns their hands red, and then the blood vessels shut down, which turns their hands white, and then they turn blue because it gets cyanotic with Raynaud's. So yes, it can be autoimmune, but I also think overexposure to cold conditions can contribute to it as well. So let's practice perfusion issues. This one, if I can get you oriented here. Okay, so we're looking at the aorta here. Here's our issue. If we were to cut the wall of the aorta out here and enlarge it, you're like, oh wait, I know what that is. Okay, here, and we have a deposition of blood here. What do you think? Aortic dissection. Okay, so this is going to be one of those false aneurysms presenting as a dissection, and you can actually get deposition of blood between the layers of the aortic wall. This one's easy. So I think it's a great picture though, where we're going to look at here's a blood vessel, and we're looking at it on end, just like a tube. And this is damaged endothelium, which creates inflammation. Inflammation's key with this. Okay, so remember, inflammation is there. We get, as a byproduct of that inflammation, what's called a fatty streak. We start to deposit cholesterol, and then we deposit fibers as well. We deposit and create a fibrous plaque, and then this plaque grows and starts to decrease the diameter of the blood vessel. And the last bad news bears is if we throw a clot here. Now, there's been some cadavers that I've worked on where they have multiple blood vessels with this fatty deposition, systemically speaking. And this is atherosclerosis. And I mean, those blood vessels get hard. I mean, they're like plasticky. Yeah, you got it. Aneurysm. Okay, so this is a ballooning in one of the arteries of the brain. Obviously, if that ruptures, it's going to be really, really, really bad. we have a backup plan for blood supply in the brain, but this is huge. I mean, this would be a huge issue. This is right after it comes off the carotid. Yep, this one's easy too. Raynaud's. Okay, so there's that white presentation. Some patients have the red first. Some people go right to white and blue. Now, there's two answers here. I think everybody knows it's an aneurysm. Okay, types of aneurysms. This one's going to be saccular, where we get it off to the one side. And this one is going to be fusiform. Okay, very good. Ooh. How do we get here? How do we let this go this long? Oh, it's just heartbreaking. Okay, thromboangiitis obliterans. So those blood vessels are getting destroyed and obliterated, right? And then the blood flow can't continue on and we'll get necrosis. All right, this is a great stopping point. We are going to continue. There will be probably one or two more lectures. Heart is a long lecture, but there's a lot of bread and butter good stuff that you'll work with here. I will see you in the next video. Shoot me an email if you have any questions.